Hello, my name's Dr. Katie Lee. I'm a clinical psychologist and lead for the Care Home Pathway with Surrey and Borders Partnership Trust. I'm here today to talk to you about how we might make sense of distressed behaviour in dementia. Sometimes this is referred to as challenging behaviour or behaviours that challenge. I tend to use the phrase distressed behaviour just as a preference for showing that behaviour has some meaning and function for the individual beneath the surface. But I might use different terms as we go through the talk today. So in terms of the content for the session, first of all, just going to give a brief overview of how the CMHTs support care homes and the way in which you would make a referral. I'm then going to zoom in a bit on understanding dementia and with a specific focus on how we might make sense of distressed behaviour when difficulties like this arise in the context of a dementia. And as we move towards the end of the talk, I just wanted to offer up some key areas to explore, areas for possible detective work to think about how we make sense of behaviour that we might see in dementia. So in terms of older people's services across the Trust, we as a Trust cover the whole of Surrey and North East Hampshire, and we have 9 community mental health teams for older people in this region. We offer support for a wide range of difficulties, which include individuals needing more complex memory assessment to diagnose a dementia. We support older people over the age of 65 with mental health concerns, either in care homes or in their own homes. And we also have an offer of support to the care homes around distressed behaviour, which could include people with a dementia or those with mental health difficulties. And indeed, people show similar behaviour difficulties at home, and sometimes those situations can be much more risky for potentially a frail loved one to manage. And we offer support to people who are experiencing those difficulties in their own homes as well. So within our community mental health teams, we have a dedicated care home pathway function available for each of the 9 areas. And within that, we have access to the intensive support team. We have a clinician within each of the services who can get involved with more complex dilemmas or ethical issues where further detective work is necessary. But we have a range of different clinicians, nurses, OTs, psychologists, assistant psychologists and so on to support the care homes within each of the areas. Our focus and offer to the care homes is very much around offering mental health advice and consultation for people who might need memory assessment or are showing behaviours that challenge distressed behaviours in a care home setting. Our emphasis, in line with national guidance, is always on promoting non-medication or what we call psychosocial approaches. But of course, there are times when medication will be absolutely essential and necessary to help that person and help reduce the risk in some situations. So it's very important that we try to disentangle the jigsaw puzzle of services, because the GP is the go-to point of contact for any physical health concerns, and we have lots of skilled matrons and district nurses also supplementing that provision. Any placement concerns would go either to the organisation funding the placement, so it could be social services, continuing healthcare for some people with very complex needs. But often it's the person's family who are responsible for sourcing a new placement. So as a mental health team, we're here to give the behavioural advice and management, both medication and non-medication, but we aren't here to find that person a new placement and certainly not to source that placement. That would not be part of our remit. In terms of referrals, all of the referrals for care homes come through the GP. And the reason for that is we want to rule out and treat any physical health difficulties that the GP might uncover. So we kind of ask for this physical health MOT before we have a referral. In normal circumstances, this would include a urine culture or urine dip, blood tests, and really a bit of a check over from the GP, looking at their medical history and their current health status. Possibly medication changes could have had a contribution as well. So this is really important, and the reason for asking for the GP to triage referrals is that we know that many behaviours of concern that arise in dementia resolve within 4 weeks, and that's because they're caused by something physical in nature. And so we have to be really sensible and proactive in making sure that the physical health and those basic blocks of well-being have been looked at before we go rushing into needing specialist mental health support and advice. There is an exception to the rule of care homes being able to re-refer someone who has previously been known to the mental health team for older people. So within 6 months of us closing a referral to our team, the care home can call up and ask for that individual to be reopened. So I think before you go through the process of contacting the GP to make a referral, it's always wise just to check if you think that person might have been opened up to us already in the past 6 months, because that will speed up the process of us getting back involved. And here on the slide are just the contact details for the different mental health teams for older people. Hopefully you're aware which area your team, your care home falls within. And please do call us if you have any referrals or need some help with mental health advice and consultation. So let's move on to think a little bit about how we make sense of dementia, first of all. Dementia in itself is a very complex diagnosis which has lots of different aspects to it that we first need to understand before we can zoom in on understanding behavioural difficulties that may arise. So as I'm sure you know, dementia is an umbrella term that captures a wide range of different subtypes, and the most common of which is Alzheimer's disease, or mixed dementia, mixed Alzheimer's and vascular dementia. But all subtypes are characterised by build-up of abnormal proteins and cell death within the brain. This is a progressive condition that is going to get worse with time. And this is why often in the later stages of dementia it can be very hard to tease apart what type of dementia that individual would have. And often we're only ever sure at post-mortem. In the early stages, people may present with a range of difficulties depending on their unique subtype, the type of dementia, but often with the changes in the brain that are happening, the early stages show slowed thinking speed, so this slowness of thought and reaction to events, and issues with memory, so this kind of slowness of retrieving things that might be quite personally significant to the individual, but they can't quite grasp the words or the memories, and things might be jumbled up in the wrong order. Often language, speech, grammar, and what we call visuospatial skills can be affected. So visuospatial skills are where we have difficulties in recognising objects, maybe how to use them or what they are, or being able to judge depth and distance. So perhaps struggling to understand the speed of moving cars and losing that sense of road safety, or not really knowing how to sit down on a chair or to walk up the stairs in the way that one used to. So those difficulties could point to a more unusual dementia subtype, but they are more common with everyone as the dementia advances, and they're not as well understood and recognised. As the dementia progresses and the changes in the brain become more widespread, people can become incredibly confused, and this can lead to also a loss of daily living skills, such as being able to sequence tasks like making a piece of toast or a cup of tea, and being able to wash or dress themselves and remain independent. And I often include this diagram of a swan to highlight to people the incredibly draining experience of having a dementia on a day-to-day basis. People might look like they're gliding along the surface okay, like a swan, but underneath, the amount of work that's having to go on in that person's mind and body to try and problem solve what's happening, where am I, and make sense of the confusion and the frustration linked with the loss of daily skills and being able to look after themselves. This can be really, really tiring, and it's why we often see a lot more behavioural difficulties as the day goes by, because the person is, quite frankly, exhausted and they've got nothing left in the tank to be able to hold it together anymore, so to speak. So in terms of Alzheimer's disease, which, as I've said, is the most common type of dementia, there are a couple of things I just wanted to mention that are relevant for care staff to really understand what's going on in the brain. The first difficulty to pull out is what we call the law of disturbed encoding. So the person, through the damage in their brain, in the memory structures of the brain, is now no longer able to lay down new memories in the way that we are able to with a healthy brain. So what we normally have is something occurs and it goes into our short-term memory store, and then that gets encoded, like saving a computer file, to the memory regions of the brain as a longer-term memory that we can later retrieve. When people have Alzheimer's, that process of saving the memories is disrupted, and what can happen is it's almost like those recent events are rapidly forgotten and disappear into the sky like bubbles rather than being saved to our memory disk in our brain. Of course, there are exceptions. Anything that's happened that's particularly upsetting or personally significant to the individual are likely to be more strongly encoded. But sometimes the details can get jumbled up and people can get quite confused in searching through the memory stores of the brain to understand and make sense of what's happening to them right now. Now, the law of disturbed encoding in Alzheimer's disease can cause people to be extremely disorientated to their environment and to time. It's likely that people might be forgetting recent conversations and losing the thread when talking to you because they're just drifting off in terms of keeping up with the recent events and what you've just said. People will ask repetitive questions and it's not their fault. It's because they can't remember the answers and they can't remember that they've just asked you. And of course, if we're not laying down new memories, we're going to be misplacing or losing items quite easily as well. What we know as human beings is that we have this fantastic machinery in our brains. Our frontal lobes have advanced over hundreds of years of evolution to become phenomenal problem solvers. And it's the hallmark feature of a human being, and that we're constantly trying to problem solve and make sense of what's happening around us and try to find a solution, often quite creatively. This is important to understand when we're looking after someone with dementia who might not remember or indeed know that they're in a care home, but are just trying to problem solve about why on earth is that front door locked? Where am I? Why can't I get out? Why are people telling me this is my home now? And people will be quite creative and innovative in trying to problem solve. And they might not start off being necessarily distressed. They might just be trying to guess the keypad code or jam the door or rattle the door because of that creativity and problem solving and this curiosity that we have. What happens as dementia advances is that people struggle to easily decipher and make sense of the world around them. And this can be very distressing. People, as the Alzheimer's disease progresses in particular, may draw on older memory stores to try and understand what's happening in their current reality. And this is what we often refer to in dementia care as time shifting, where people's memory shift back or roll back, sometimes called rollback memory, to an earlier stage of their life that might be better crystallised or preserved. This can cause all sorts of problems, as you can imagine, because as a carer, you might be working to support a resident with dementia who has a very different outlook to your own. So you're knocking on that bedroom door, going to assist that person with an essential care task, whether it's changing a dressing or helping them go to the toilet to get washed. And they might think that they're in a hotel room and be utterly confused about who you are, why is this person coming in, who on earth do you think you are asking me to take my top off? This clash in outlook, or what we call frames of reference, if we're using the sort of more academic understanding, can cause all sorts of situations and difficulties to arise for both staff and residents, because we're not on the same page as the person who might believe they're in a hotel or at their place of work, and it clashes with the task that we might need to achieve with that individual. And what we need to do is to try and work with the person to communicate with them in a way that they feel safe, understood and reassured as much as possible. Some of the other consequences of time shifting when people's memory rolls back to an earlier period is that the person may think they're much younger than their actual age. And as dementia progresses, people might not recognise their own reflection, or they might talk to their own reflection as if it's a stranger or a parent or an older relative. In the later stages of dementia, people may begin to ask and call out for their parents and have lost that understanding about how old they are and that their parents are long deceased. And that can be a real sign of distress. We know when people are calling out for mum or dad, we need to be paying attention, because we call for our parents or our nearest loved ones when we're really frightened or we're really in pain and uncomfortable. So we need to be watching for that behaviour very closely indeed. It might be that the person thinks they're at work, and I have memorable experiences of working on a dementia ward where one of the people we were caring for believed that she was the head chef. We were all going to get fired, and we all would routinely get kicked out of the nursing office, and she'd give us our marching orders. It was very challenging to manage that. So she was the boss, and there was no arguing with that, and how to dance with her on that particular ward. People might be very disorientated to others around them. I'm sure we've all had experiences in supporting people with dementia where you walk into a room and someone thinks that you're a relative or a friend or a neighbour, and it can be very difficult to know how best to answer and deal with those situations when they happen. And finally, the consequences of people's memory rolling back is that they might be identifying with beliefs and values that are now completely unacceptable and indeed offensive. So we often have a dilemma in dementia care where people might have quite old-fashioned views and offensive views about people's skin colour, sexual orientation, ageist, sexist ideas, and it can be very hard for carers to deal with those when it's just really not something we're used to in today's society. So how does this link to distress behaviour, which is the focus of today's talk? Well, as I've said, experiencing dementia must be incredibly draining and exhausting. The confusion, the increased dependence on others must cause everyday difficult emotions to arise. And for many of us, we want to be independent, we want to do things ourselves. Just imagining that sense of failure, let alone the embarrassment and the humiliation that we could experience through needing help. We can all sympathise with what this individual is going through. And every day they're kind of going through this emotional roller coaster afresh because possibly their memory stores aren't working as we'd expect them to be. It might also be that the person has all these feelings and needs and wishes that they want to express, but the language skills just aren't there to share what they're thinking and feeling. And so as a result, that frustration has only one way to show, which is through the person's behaviour. And we know that people that have lost the power of speech and those verbal skills are much, much more likely to show aggressive behaviour. It's a known trigger because of the immense frustration that we get when we can't talk, when we can't share, when we can't connect as easily. Often the crux of the issue is when people have lost abilities and skills, but they don't have any insight into those reduced abilities and skills. And this is where confrontations occur. And we need to be very careful in how we dance with individuals to help them feel reassured and safe and as empowered as possible. So let's move on to think about distress behaviour in dementia, what we sometimes might refer to as challenging behaviour as well. What we know in a nutshell is that all behaviour happens for a reason. There's always a cause, there's always something beneath the surface that we might not be able to see that's driving that behaviour. So we've got a picture of an iceberg here just to try and hold in our minds. What we're seeing in the behaviour is very much the tip of the iceberg, and beneath the surface there's all sorts of emotions, frustration, anger, difficult thoughts, needs, all sorts of things happening beneath the surface that the person might not be able to easily share. And often behaviour is an attempt to meet an important need for that individual that they're struggling to show or satisfy. Positive behaviour support is the recommended approach for addressing behaviours that challenge. And we have a second talk recorded which goes into a bit more detail about positive behaviour support and how we might de-escalate and calm down certain situations within this mainstream approach. In a nutshell, the emphasis within PBS is on promoting someone's well-being, and that we need to take a detective-like approach to understanding why the behaviour happened in the first place. And it has a huge emphasis on, if we do give the person the things that they need to promote well-being and activities pitched at the right level, there will be less time for the distress behaviour to surface and happen. And so often as Care Home Pathway colleagues, we're trying to encourage care home staff to really get to know the person and really find out how to make a connection with them, because it really does pay off in the long term if we invest in the individual's well-being and not just focus on reacting when behavioural difficulties arise, because by then it can be very difficult to calm someone down. So why does distress behaviour happen? Well, there are a number of different factors, and I've massively simplified them onto one slide and we won't be able to capture them all. I'm just picking out a few key things here. One of the first things to say is that the things that trigger a behaviour aren't necessarily easy for us to see on the surface and when we're looking at the individual. So it could be things that are happening in the individual's body, both in their bodies but also in their minds. So it could be that the trigger for a behaviour is that frustration of the language problems, or factors that are unique to the dementia that they've got, that visuospatial impairment and the emotions this is causing. It could be that the individual's having some flashbacks or some memories from a traumatic time of their life. And of course, we mustn't forget the basic building blocks of well-being, that sense of being pain-free, having a feeling of comfort in our bodies, a sense of tiredness, dehydration, all these health issues that could make us feel really yucky and uncomfortable are so important to pay attention to when we're looking at understanding behaviours that challenge in dementia. What we know is that there was a recent study in 2019 completed by Cunningham and colleagues, and it found that pain was the key reason for behaviours that challenge in 47% of the people that were reviewed in a large-scale study. The second most common factor driving the behaviour was the approach of the caregiver, which is mentioned on this slide as an external factor. And it's really hard for us to admit this, but I know myself there are times when I put my foot in it, both at work and at home, and often it's our approach in dementia care, this clash of realities, this clumsiness of how we explain or rush or reassure people too hastily, that can be a key trigger in how the person then escalates in their behaviour and how the behaviours might begin. So we have to be very reflective in dementia care, because the environment, the caregiver approach, huge contribution to how settled someone might seem in their environment. So it's always important to think about, how would you feel if you were told you lived in this care home now and this was your home? Would you want to sit next to the lady who's screaming out for mum all the time? Sit in parts of the home where it might be a bit smelly or overstimulating? or where there's just a really non-dementia friendly design that doesn't help the person understand what's going on and help promote independence. So these external factors and the internal factors, the person's mood, their trauma history, all of these things come together to build a picture about why the behaviour is happening, why it started and what's keeping it going. And what we know from this paper that was written just last year is that most behaviours have more than 4 contributing factors. So things aren't necessarily straightforward in dementia care. It's not always just the case that we find one thing and we've cracked the case. We have to consider multiple factors that are contributing to causing and perpetuating that behaviour. So what I've got here is 3 slides just with some key questions to think about as care home staff when we're seeing distressed behaviour in someone with dementia. And I'd like you to think of yourselves when you're engaging in the process of understanding behaviour in dementia as detectives, behavioural detectives, and get that mindset of curiosity as best as you can to really try and get beneath the iceberg and get to the bottom of why this behaviour is happening. What can be really important is sitting down and trying to develop a really clear description, first of all, about the behaviour and what exactly is happening. So we want a lot of clarity here about what is the person doing and saying and how might they be feeling when they show this behaviour. Okay, so it might be that you've got some ABC charts, or you could ask different colleagues about what the person is saying. This gives us such a valuable insight into that person's current outlook. Then we can channel our questions to the relatives about how best to manage that period of rollback memory that the person's gone back to. We need to be thinking about making some links. How does the behaviour link with the person's life history? Have they time shifted? So when they're calling out for Joan, who's Joan? Okay, well, Joan's the dog that got run over on the road, and the lady's gone back to that time in her life. We need to know who it is that the person is searching for and what they're trying to achieve to best dance with their reality and their current outlook. It's always really important, moving on to the bottom half of the slide, to try and pinpoint when did the behaviour start, the onset of the behaviour. If there's a sudden change in someone's presentation, we need to be considering physical health causes and really looking at that in a proactive way. And we know that people with dementia are highly likely to develop delirium. We've got specific guidance and recommendations around delirium that we can signpost you to as mental health teams if you think that's an issue. Like a detective, try to explore the patterns in the behaviour. So is it happening with certain people, certain times of day, different locations in the care home, or during certain care tasks? So is it only ever happening, the aggressive behaviour, during personal care, or at meal times, or when Peter sits next to Mary at the dinner table? Okay. But what's most important as well is to find out when the behaviour is not happening, so the exceptions. And it's quite rare to see someone that shows the behaviour 24 hours a day. And there are always these glimmers of exceptions that we need to be curious about, like detectives. So who are the people that don't seem to have any issues with personal care with that individual? Who are the people that have more success, and how do we learn from them? And I believe very strongly that often in my work as a psychologist, I'm learning from care staff as the experts in knowing that unique individual. And we're trying to just find that care staff, the member in the team that has this really lovely approach with them. And then we can capture that and try and upskill the rest of the team. So please pay attention to the exceptions as well as the patterns. Further detective work questions involve reviewing the person's medical history, and you might want to do this with the GP or with one of the nurses if you have them in your homes. So looking at medications, and are there any recent changes that could explain the difference in this individual's behaviour or making a contribution. So knowing that person's medical history is key. As we said before, pain is a massive contributing factor to distress behaviour. So we need to be looking for signs of pain, and sometimes we'll go up the pain ladder just to see if it helps. Of course, we need to make sure we don't leave people excessively constipated and manage that alongside. Might they have an infection or a delirium? So this is where we might consider having a urine dip or culture just to see if there's a need for some antibiotics. It could be a chest infection as well of some description, so looking for signs of this and signs of ill-being. And we must also pay attention to what is known as slow triggers, things that have a delayed impact on behaviour and often happen inside the body. Hunger, thirst, dehydration, boredom, these are all factors that are slow triggers for someone's behaviour. And again, these might get more problematic as the day goes by. Diarrhea and constipation can make people feel really uncomfortable in their bodies. So we need to be looking for that and how often they've passed a bowel movement, because that could be actively treated and resolved. We know at the time of recording this as well that there are significant challenges being faced by care homes due to the COVID-19 outbreak, and those factors could be having a huge impact on our residents. We have a separate talk on how we might support people through times of medical isolation that I encourage you to listen to. But when someone's favourite staff member is having to take time off work for health reasons, this can have a huge effect on people. And when we're under stress as a staff team, people with dementia are going to pick up on that atmosphere and feel quite unsettled in themselves. So it's really important to consider whether there are changes in the home and people's routine that might be having a direct impact on the distress behaviour that we're seeing. And of course, we must mention that relatives and loved ones aren't coming in the same way, and that could be a huge trigger in its own right. We need to be creative in finding ways to connect with loved ones at this difficult time. I would always recommend that you contact the family. The family hold the key to unlocking the meaning and function of the behaviour. You probably all have some form of This Is Me or life story document on admission to the home. Please don't let it collect dust in the file, particularly when we're seeing signs of distress behaviour. Dust it off, get it out, have a look at what you've captured, and then try to zoom in and speak to the relatives about how what the person's saying and doing now might link with the life history. And that's why, as I said earlier, it's so important to pay attention to what the person is saying and doing, so that we can understand the outlook and where they might have time shifted to. At the very least, if we haven't gathered a life story, try to find out what the person's previous jobs or career were. What were their hobbies and interests? Were there any important routines that they like to follow in their daily lives or in their weekdays? And what about now? What kind of cues the person in now? What will light them up in terms of a conversation topic, an object, an activity? And we all need a treat now and then. So what would be a lovely treat if we needed to engage or distract or soothe somebody? These are just basic things to ask if you haven't captured a life story on entry to the home. What's also important to ask the loved ones is about the early warning signs of distress. And as we say in the second talk, so important to act early when the person is beginning to get upset, rather than try and soothe them when they're really, really angry or really, really sad. So we need the relatives' tips about how do we support the person when they're upset and we notice those early warning signs. So what have they found worked? How did the person used to cope in the past? And how can we hold that in mind now to support them? As I said earlier on the iceberg slide, often behaviour is an attempt to satisfy some sort of need that's driving that particular action in that unique individual. And Ian James has collected a number of common unmet needs for dementia care, which are included in this slide. So what we know is that behaviour could be driven by physical comfort or wanting to be free from pain, and this is particularly true when people are walking. They might be just trying to take their mind off the pain that they've got through sitting on a pressure a pressure sore, or having some joint pain. People need to feel safe, maybe for themselves, but also being concerned about the welfare of other people's safety in dementia care because of rollback memory. We all as human beings need a sense of touch, love, belonging, and it could be that the behaviour is driven by that need, that the person just doesn't have any intimacy anymore or any sense of connection to visitors or loved ones. It could be that the person's is not feeling particularly dignified or respected or valued, and that's the driver for the behaviour. And of course there are other things that might be a bit further up the hierarchy of needs, like having a sense of fun and spontaneity, but keeping busy and having the ability to be free from boredom is a very common unmet need for distressed behaviour in dementia. And we know ourselves, we very rarely just sit down for long periods. We need that sense of doing something, being busy, being occupied with meaningful tasks. And if we're not engaged in such activity, it can actually cause cell death in the brain. So boredom is a really key area to expand on when you're thinking of ideas to support the person. If we're still not sure from all this amazing detective work that you've done, and the jigsaw we're building, it might be that the Care Home Pathway team will ask you to complete some more questionnaires. We have a number of different questionnaires for different presentations that could help illuminate what's going on and get to the bottom of what's happening and what the function is of that behaviour. In terms of intervention ideas, I'm a strong believer that if you do a really good, thorough, analytical assessment, rich with detective work, you are then going to have an understanding of what's driving the behaviour. And hopefully by then, once you've understood the behaviour and what's causing it beneath the surface of the iceberg, the ideas of what to do should naturally fall into place. But what I'd like to say is if you feel you are lacking in inspiration, you just feel stuck for where to go with intervention ideas, please contact your Care Home Pathway within your local CMHT, and we'll be able to hopefully signpost you to a whole range of resources. So we, as a mental health service, have a whole treasure trove of resources. I think we've probably got a leaflet on everything. We hope we have anyway by now. So we'd be more than happy to share ideas and signpost you to resources if you're feeling a bit stuck. So that's the end of the talk today. I hope it's been helpful just to give an overview of dementia and thinking about how that sets the landscape for why people might show distress or challenging behaviour. Please go and think like detectives. I know these are difficult times, but if you've got someone who is really distressed, it's worth making the effort and the investment to do this groundwork and this detective work. And if you do get stuck, please don't hesitate to contact us. Thank you very much.